Hello, I am Dr. Javed Butler, Patrick A. Lehan Chair in Cardiovascular Research, Professor and Chairman of the Department of Medicine and Professor of Physiology at the University of Mississippi in Jackson, Mississippi. Welcome to the program entitled The Evolving Science of Novel Targets in Heart Failure with Reduced Ejection Fraction, What Every Healthcare Professional Needs to Know. In this program, we will discuss the current pathways which we use to modulate the outcomes of patients with heart failure with reduced ejection fraction. We will talk a little bit about the residual risk and why we need novel therapies in patients with heart failure and reduced ejection fraction. And then finally, some of the upcoming trials and novel pathways that we are also researching to find further cures for our patients. So let's first start our discussion talking about this concept of residual risk. We all know over the past, say, 3 decades or so, we have come up with a lot of therapies that have improved the outcomes of patients with heart failure and reduced ejection fraction. Starting with therapies earlier with ACE inhibitors, and then some therapies, trials done with angiotensin receptor blockers, beta blockers, MRAs, mineralocorticoid receptor antagonists. We had this very huge positive trial called Paradigm trial with angiotensin receptor neprilysin inhibitors, valsartan and sacubitril. We have device trials like defibrillators and pacemakers, biventricular pacemakers. So we have really changed the face of how we used to treat heart failure with reduced ejection fraction, just say even about 2.5, 3 decades ago. So why worry about more pathways? And the reason for that is that on a relative scale, we have significantly improved the outcomes for our patients. Nevertheless, these patients continue to be at a particularly higher risk despite those advances. So even if you look at recent data, epidemiologic data, when patients develop heart failure with reduced ejection fraction, you're looking at 40 to 50% 5-year mortality. Even if you look at, say, the Paradigm HF trial. So I would like to highlight this trial because A, these are very contemporary data, right? This trial was just recently completed. This trial included, the eligibility criteria included people with, GFR less than 30 was excluded. Most of the clinical trials have relatively a little bit younger population and with less comorbidity burden. So you would expect that their outcomes are a little bit better than what may happen in real life practice. But importantly, this group of patients were really well treated because the control arm was treated with high doses of enalapril. The average dose was about 18.8 milligram when they were trying to achieve 10 milligram twice a day. And these are much higher doses than mostly what are being used in the clinical setting. So, and 70% of the patients were class 2, 40% or so patients did not have a previous hospitalization. So this, by all accounts, would be a patient population that you would think that the residual risk is pretty low. And in this trial, over a quarter of the patient, over 25% of the patient, ended up reaching a primary endpoint, which is cardiovascular death or heart failure hospitalization. So there was a lot of residual risk in these patients in the trial. If you look at the 1-year outcome in patients who are otherwise stable, we are looking at about 10% 1-year mortality. Remember that it used to be 25, 30%, so 10% looks pretty good. It has come down. But just think about how much we appropriately care, say somebody who comes in with myocardial infarction. The chances of dying 1 year after myocardial infarction are actually less than 10%. So 10% is a lot of residual risk. Well, are all heart failure patients at the same risk? Well, it turns out that if you develop worsening heart failure, in other words, you used to be sort of stable on medical therapy, but now the heart is not that stable and you develop worsening symptoms, you get hospitalized. Now you're talking about 25 to 30% 1-year mortality risk, and we all live with this issue of heart failure readmissions, recurrent hospitalizations. So after worsening heart failure and hospitalization, we are talking about 25% 1-month readmission rate. So there is plenty residual risk that we have in these patients that we need to find novel therapies to reduce the risk further. So let's take a little bit of a historical detour of how we have developed therapies for heart failure with reduced ejection fraction. So what we learned over many years is that let's do a thought experiment. So you had myocardial infarction, or had chemotherapy, adriamycin exposure, or had myocarditis. You had something that dropped the ejection fraction from normal 55-60% to say 35%. Well, logic would suggest that in the absence of a second insult, in the absence of another myocardial infarction or something like that, your ejection fraction should just stay at 35%, but that doesn't happen. And the reason why that does not happen is because of adverse neurohormonal activation. So the secondary further progression of the disease and worsening of heart failure is actually related not to why you developed heart failure, but what happened to the body in response to development of heart failure. So we have a lot of receptors in the body, carotid receptors, baroreceptors, renal receptors, and all of these sense any changes in cardiac contractility, the stroke volume, cardiac output. And it doesn't have to be dramatic. It doesn't have to be cardiogenic shock or hypotension. These subtle changes in cardiac output and hemodynamics are sensed, and the body interprets that as we need to do something to avoid further escalation of hemodynamic abnormalities, and in response to that, all the neurohormones go up. These neurohormones like norepinephrine, angiotensin 2, aldosterone goes up. And what happens in return? Your heart rate goes up. You get vasoconstriction. You have sodium and fluid retention. All of these things that in the short term are actually good things because they stabilize the hemodynamic milieu. The problem is that in the long term, they are associated with adverse outcomes. In the long term, they lead to cardiac remodeling, energy metabolic abnormalities, ATP production abnormalities, extracellular fibrosis burden, apoptosis, certain cardiac death, and progressive dilatation of the heart and decline in the cardiac function. So it is because once we understood this pathophysiology of abnormal neurohormonal activation, we started coming up with neurohormonal antagonists, ACE inhibitors to antagonize angiotensin 2, beta blockers to antagonize norepinephrine, followed by MRAs to antagonize aldosterone levels. So we had an unbelievable success in improving outcomes for patients with heart failure, reduced ejection fraction. So we then thought, well, what about some other neurohormones? Let's start doing the same thing with other neurohormones that are activated that are associated with worse outcomes also, endothelin, vasopressin, and we did develop those drugs and we did test them in patients with heart failure, but unfortunately those attempts were not successful in improving the outcomes further, which kind of sort of tells us that we are maybe reaching a ceiling of impacting the bad neurohormones. So that was a time to step back and maybe reassess and look at heart failure a little bit differently. And that is what the Paradigm HF trial with valsartan sacubitril did. And what that trial did, what they said, well, we have been working in attenuating the impact of bad neurohormones. Can we do something to accentuate the effect of the good neurohormones? So good neurohormones are not present as much as they are needed in the body to counteract the bad neurohormones. So why don't we try to up the good neurohormones? So that was what valsartan sacubitril did. You give sacubitril, neprilysin inhibitor, your levels of natriuretic peptide and vasoactive peptide go up. You try to bring a balance, and by bringing that balance, you improve patients' outcomes. So that led to the Paradigm HF trial, and we all know the results that led to improvement in outcomes for the patients. So where are we now? Well, where we are right now is I went into significant details related to residual risk in the Paradigm HF trial. So with the best of the best therapy we have, 90+% beta blocker use, high dose ACE inhibitor in the comparative arm, and then obviously a potent drug with valsartan sacubitril. What we learned, as I said, that a quarter of the patient reached the primary endpoint, still a lot of residual risk, high rates of readmission. What can we do? Well, this whole paradigm got changed once we started getting all the data from SGLT2 inhibitors. So we know that the SGLT2 inhibitors were developed for management of diabetes, for management of hyperglycemia. And when the cardiovascular safety and outcome trial, just in general diabetes population, high-risk populations were being done, all of a sudden we started getting all of these signals that the heart failure outcomes started getting pretty good. The heart failure hospitalizations went down in patients who already had heart failure, and those patients who did not have heart failure, new onset heart failure or new heart failure hospitalizations went down. So this is great news, sounds like a good idea. And the question is, could this drug be used to improve heart failure outcomes? So that was one part. The second thing is that if you look at the pharmacodynamic effects of SGLT2 inhibitors, they kind of sort of go beyond just glucose management, right? So you have preservation of renal function, natriuresis, decrease in visceral adiposity related inflammation. You have sodium hydrogen exchange effects. You have impact on LV remodeling. You have effect on aortic stenosis, diastology. There's a whole lot of things that happen with these drugs, and we continue to learn a lot. There's a lot of mechanistic research going on, and we will continue to learn. But the question came up is that what do all of these benefits have to do with diabetes? Because one can hypothesize, one can theorize that if you give these drugs and if they are good for heart failure patients, they should be good for heart failure patients even if they don't have diabetes. So that led to an era of designing several large-scale trials in patients both with heart failure with preserved ejection fraction and heart failure with reduced ejection fraction to see what are the clinical outcomes with these drugs. So multiple trials being done, as I said, but the first trial reported out the results, which was DAPA-HF. DAPA-HF was a trial of patients with low ejection fraction, less than or equal to 40%, that were randomized to dapagliflozin or placebo and followed for long-term clinical outcome. And what a great result, what a pleasant surprise. Substantial reduction in this cohort of patients, very well treated again at the baseline. RAS inhibitor use, beta blocker use, 90+% range, MRA use, 70% range. Really well treated group of patients. And there was a substantial 30% reduction in the primary endpoint of cardiovascular mortality, heart failure hospitalization, or urgent outpatient heart failure visit. 18% cardiovascular mortality reduction, all-cause mortality reduction was seen. And there were a lot of data presented in improvement in quality of life scores, and quality of life scores not just on average, but how many people improved by 5 points and 10 points and 15 points. All of those benefits were accrued. So now all of a sudden, rather than having a three-pillar, triple therapy for heart failure, RAS modulation with ARNI, sympathetic modulation with beta blockers, and aldosterone modulation with MRA, now it looks like we will have a fourth pillar with SGLT2 inhibitors. However, I'm sure that the regulatory agencies and the guidelines will review the data, and we will have specific professional society guidelines coming out soon, what and how we should use it, but the results were very positive. However, there are a couple of things that people were really interested to see what happens. One is that is the benefit the same in people who are taking ARNI at baseline? And the answer is yes. But the bigger question was, does this drug work in patients without diabetes? And the answer is absolutely yes. The benefits are almost identical in patients with and without diabetes. So what does this trial tell us conceptually? What this trial tells us conceptually is two big things. One is that the residual risk can be further modulated, even on the standard good therapy. By giving additional medical therapies, you can further improve the risk profile for these patients. But the second thing, it also tells us that unlike all the previous therapies that were acting on various aspects of neurohormone, good or bad, that by using SGLT2 inhibitors, a completely different pathway, you can improve outcomes. So now it opens our mind towards two possibilities. A, look for further therapies to reduce the residual risk in patients with worsening heart failure, and B, to look at novel pathways and novel ways and means by which we can improve outcomes for these patients. By the way, so the SGLT2 story will continue to evolve. There's a lot of other studies going on in heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, in the hospitalized heart failure setting, functional capacity, quality of life. So we will learn a lot more about SGLT2 inhibitors per se. So what are some of the other novel pathways that we can talk about? So let me talk about two of these pathways and tell you what's going on in terms of the clinical research in those pathways. So one is the nitric oxide soluble guanylate cyclase CGMP pathway. So what is that pathway? Well, we do know that patients, for normal physiologic function, we need not nitric oxide to go ahead and stimulate the enzyme SGC, soluble guanylate cyclase, and SGC then in turn increases the level of CGMP. CGMP then leads to PKG signaling, and PKG signaling by phosphorylation of a whole series of enzymes does a lot of good things in the body. This is really a ubiquitous system. Vascular function, renal function, cardiac function. There are a whole host of effects on the body that can be improved, and then secondary benefit in terms of the reducing the risk of apoptosis, reducing the risk of renal progression, reducing the risk of fibrosis. All of this has been studied sort of in the basic science literature, and there is a plethora of good things that can come through the nitric oxide pathway. However, unfortunately, in patients who have heart failure, there's a higher burden of oxidative stress. And what happens with oxidative stress is that the nitric oxide is shunted in an opposite direction, and there is not enough nitric oxide available to stimulate soluble guanylate cyclase. And if you don't stimulate soluble guanylate cyclase, all the downstream benefits get attenuated or reversed, or you don't get those benefits. So what can we do to increase soluble guanylate cyclase stimulation? Well, one thing is, why don't we give nitrate donors? That is what nitrates are. So the sublingual nitrate we take for angina, well, that's what they do. They are nitrate donors. Isodil, they are nitrate donors. So we can take nitrate donors. The problem is that one, with taking nitrate donors for angina for short term, it's fine, but in the long term with repeated exposure, you develop tolerance. Very well known for a long time. So you develop tolerance. Two, even if you increase the supply of nitric oxide in a milieu of oxidative stress, you will nevertheless have this competing shunting of nitric oxide to nitrite pathways, which is actually not beneficial and not necessarily get soluble guanylate cyclase activation. And then the third issue is that there are no large-scale data anyways for improvement of outcomes in broad range of patients who develop worsening heart failure. So if that pathway cannot do it, how about we go to the other end? At the end of the day, the cyclic GMP, which is produced by SGC stimulation, is degraded. Look at the parallel idea here. We talked about the natriuretic peptide and using valsartan sacubitril to decrease the degradation. Well, can we apply the same principle here? Can we apply the same principle by reducing the degradation? And we do have drugs that reduce the degradation, which are phosphodiesterase inhibitors. So one thing one can do, well, why don't we give phosphodiesterase inhibitor to decrease the degradation? So if we cannot increase the production, let's try to decrease the degradation. There are two problems there. One is that the primary problem is decreased production. So decreased degradation may have some benefit, but nevertheless, you're trying to increase the circulation by decreasing degradation of something which is already not there. In other words, the production is low, the actual levels are low. Sure, it may help by decreasing the degradation, but what we really need is for the levels to go up through the upstream pathway rather than the downstream pathway. The second issue is, again, like nitrates, we really don't have long-term outcomes data with phosphodiesterase inhibitor to see whether they will benefit or not. Now, in a parallel disease state, not in heart failure with reduced ejection fraction, but in heart failure with preserved ejection fraction, which is not totally relevant to what we're talking today, but nevertheless, in heart failure with preserved ejection fraction, we know that with the use of nitrates and with the use of phosphodiesterase inhibitors, we have not been able to improve outcomes, and those couple of studies have been published. So then what can you do? Is there any other means by which we can increase production of cyclic GMP? Well, why don't we just bypass the nitric oxide donation or the degradation and just directly stimulate soluble guanylate cyclase. Just directly go and stimulate the enzyme directly. Is there any drug that can do that? And the answer is that. So there are soluble guanylate cyclase stimulator called vericiguat. It's a drug that can go to the soluble, so it goes into the cell, and the soluble guanylate cyclase, which is there, it can directly stimulate that. So one might expect if you stimulate that, your cGMP levels will go up, your PKG levels will go up, and further downstream phosphorylation of all of these a whole host of enzymes affecting various aspects of cardiovascular physiology will improve, and one can potentially improve outcomes. Is there any data to suggest that that will happen? And the answer is yes. There was a large phase 2 study done called Socrates Reduce, where vericiguat at various doses were given ranging from placebo to up to 10 milligram in patients with heart failure and reduced ejection fraction. What did we learn from this? So this was a dose-ranging study, and what we found was a dose-related impact of vericiguat in these patients with worsening heart failure. So these were the people recently hospitalized for worsening symptoms after being stable. These patients had a substantially more reduction in NT-proBNP levels or natriuretic peptide levels when they were given vericiguat at 10 milligram doses. We all know that natriuretic peptides have a very tight link with outcomes in these patients. So these data are certainly not definitive, but kind of makes you really excited that there's a dose-response association, and the highest dose led to a substantial reduction, a statistically significant reduction as compared to placebo in NT-proBNP levels. Now again, phase 2 studies, by definition, are not powered for clinical outcomes. And then we were looking at 4 different doses. So we have to be a little bit cautious in how we interpret these data. But what was also encouraging was that the left ventricular ejection fraction with 10 milligram was going in the right direction. So some idea about potential reverse remodeling. And on top of that, the clinical outcome for these patients, short-term follow-up, few number of patients, I realize that it's a phase 2 study, but also we're going in the right direction in terms of the clinical outcome. So if you look at, you start getting a good sense, A, is there a residual risk in patients with worsening heart failure? Absolutely yes. People who come into the hospital or get IV outpatient diuretic are even at a higher risk. Do we need to do something to modulate their residual risk? Yes, we do need to do that. Is there any precedence that by non-neurohormonal pathways, alternate pathways, you can modulate risk? Absolutely yes. SGLT2 story tells us that we can do that. Does the physiology of vericiguat make sense? Yes, it does make sense. So have we tested in some patients to see whether it has the potential to improve the outcome? The answer is again yes. Socrates Reduce gives us a good sense that these outcomes can potentially be improved. So this is time to look at a large outcomes trial to see what happens in an adequately powered trials for clinical outcome. And that trial was conducted called the Victoria trial, where patients with worsening heart failure, so these were the patients who were either recently hospitalized within 6 months or required outpatient IV diuretic therapy. These patients were randomized to placebo or 10 milligram titrated dose of vericiguat and were followed long-term clinically for clinical outcomes. And I'm really excited to share that just this morning, when I'm speaking here, just this morning, there was a press release that the Victoria trial met its primary endpoint of improvement of clinical endpoints. We do not have any data. I would assume over the next few weeks we will see more data, maybe a presentation, maybe a publication to look at the detailed data. But this continuum of making physiologic sense to preliminary data being good to now this press release makes us really excited to find out the results of the Victoria trial. Is there any other large-scale trial which is going on in patients with heart failure reduced ejection fraction? And the answer is yes, and that is the Galactic trial with omecamtiv mecarbil. So another thing, remember I was talking earlier in the physiology that with decreased contractility of the heart, you have this neurohormonal activation and hemodynamic abnormalities. Well, why don't we do something to increase the contractility of the heart? And that is being tested in this trial called omecamtiv mecarbil. the traditional inotropes, by increasing the CAMP levels and cytosolic calcium burden, are actually good contractile agents. They do increase cardiac output. We all have used these drugs like dobutamine and milrinone and so on and so forth. The problem is that in the long run, they actually don't improve outcomes. They actually worsen outcome because in part related to the risk of certain cardiac death. So the question is, can we find some safe inotrope? And that is what we hope omecamtiv mecarbil is, that it increases the systolic ejection time by increasing the affinity and interaction between actin and myosin, and by doing so, it can increase cardiac contractility. There is a lot of preliminary data. I talked to you about Socrates reduced. There are actually both in-hospital and outpatient data in heart failure patients, all published data looking at the use of omecamtiv mecarbil to look at what happens to the outcome for these patients, and all the things look like this will be a good option potentially for patients with heart failure and reduced ejection fraction. This trial is ongoing. We have no idea about the results. There was a little bit of a concern of a very small troponin leak, so people are very interested to watch that signal carefully. That did not translate into any adverse clinical outcome, as I said, both in the inpatient and the outpatient earlier studies. And this drug also brings a lot of potential hope for the patients. But again, we don't know the results, and that's why we do trials, and we need to wait for the results for this trial as well. So this is sort of a big picture of where we were, where we are, and why we need to worry about the next steps. So I will end the presentation by saying a couple of things. One, patients with heart failure are at a very high risk for adverse outcomes. Even with therapies, a lot of the residual risk is pretty substantial. 40-50% 5-year mortality, around 10% 1-year mortality. But if you develop worsening heart failure, you come into the hospital, you're talking about 25-30% 1-year mortality, about 20-25% 1-month readmission, 50% 6-month readmission rate. So there's a lot that we need to do. We are in a good spot right now. We have DAPA-HF and dapagliflozin positive, and although we don't know the details, Vericiguat Victoria trial this morning had a top-line press release that that trial also met its primary endpoint, and we will learn a lot more with many other SGLT2 trials that are ongoing, and also with omecamtiv mecarbil. The challenge for us right now is implementation, because there are all of these scientific data that we know can improve patients' outcomes. However, these drugs, their pickup at the pace at which they get picked up and be used in clinical practice still is not ideal. And how do we use that? We need to take heart failure just like we take any other cardiovascular disease. These patients are at high risk, and we need to optimize the therapy. Think about high blood pressure or diabetes or dyslipidemia. These patients by definitions are asymptomatic, but we will never not treat somebody with blood pressure of 180 or somebody with hemoglobin A1C of 10 or LDL of 180 saying that these patients are doing well, they're asymptomatic. I will wait for things to get worse before we treat. No. We treat aggressively so that we can avoid worsening. Heart failure is the same, regardless whether they are less symptomatic or they are more symptomatic. We know how to improve their outcomes, and we need to aggressively use these therapies across the spectrum. Thank you very much. I hope that this participating in this activity was useful for you. Please continue on to answer the questions that follow and complete the evaluation. Thank you very much.